I'm a clinical hematologist. My main interest is in leukemia, lymphoma, and myeloma treatment. I've been doing research for a long time now, in particularly myeloma and lymphoma. In Australia, people with multiple myeloma, which is basically a cancer of the bone marrow, is getting more common in Australia because our population is aging. Multiple myeloma is not a curable but treatable disease. So in Australia, the standard of care as a first line, we break down the patient into two parts. One part of the patient, if they can have stem cell transplant, they have combination treatment. Usually in Australia will be Velcade, lenalidomide, and dexamethasone, followed by stem cell collection and then stem cell transplant. But majority of the patient, because they are elderly, they cannot have stem cell transplant, which is a very intensive undertaking. So they will have Velcade, dexamethasone, and lenalidomide. We call VRD, usually given as monthly treatment for roughly about a year. And then some patients will have maintenance lenalidomide until the disease relapse. Unfortunately, myeloma, no matter how you look at it, the disease always come back. Sooner or later, it always come back. That is when we have to go through, look at the patient's profile, the major comorbidity, and then pick the best treatment for the patient. And this trial, DREAM7, is comparing patient who has relapsed myeloma after at least one line of treatment between the standard of care. In Australia, the standard of care, one of the main standard of care after relapse of the myeloma is daratumumab plus Velcade plus dexamethasone, the steroid. So this trial is comparing a drug called belantamab in combination with Velcade and dexamethasone. So what it does with bispecific antibody is one part of the antibody bind to the cancer cell. In this case, will be myeloma cell, the plasma cell. The other side bind to the T cell and bring the T cell in close proximity to the plasma cell, the cancer cell, and activate the T cell directly and use the T cell to kill off the myeloma cells. And the result has come up that comparing to daratumumab, Velcade, and dexamethasone, belantamab plus Velcade and dexamethasone have a longer, significantly longer progression-free survival by at least almost 2 years. So the patients stay in remission for longer. This is something that in the future, hopefully, when government allow it to be put on PBS, it is another option for our myeloma patient who have relapsed disease. Yeah, I just want to my patient have the treatment as good as any other patient that can get in bigger city. Gold Coast is small. If a patient want to have a good trial, a good drug, quite often they have to go to other places. Brisbane, some people even have to go interstate to Melbourne and Sydney. By doing our trial locally, our patient don't have to travel so far away. They can stay at home, stay close to where they are, and I always want the best outcome for my patient. Any drug that we have, there's always a drug that's better out there. Just waiting for time to discover. And we, just like anyone else, we want to have the best drug that's available for our patient. I always tell my younger hematology consultant that we are actually at the golden age of hematology breakthrough in terms of treatment. By the time I retire, most likely that's what I'm going to tell my children. This is the golden age because we are transitioning from chemo-based treatment to immunological-based treatment. And it is already happening in lymphoma with the CAR T cell. And now we're going towards bispecific antibodies, which is the cheaper option as compared to CAR T cell. So we're doing a lot of trial on bispecific antibodies in myeloma now. And myeloma, just to give you, put things into perspective. In 2005, myeloma patients only have 2 to 3 years to live. Now, as we are speaking today, it is close to 8 to 10 years.